So today we are joined by Dr. Cenk Acar. Dr. Acar received his medical degree from DEU University in Izmir, Turkey, in 1991. He practiced as a GP and emergency physician after medical school. He completed his residency in anatomic and clinical pathology at the University of Miami in Florida, followed by fellowships in cytopathology, hematopathology, and immunopathology from 1999 to 2008 in the same institution. He is a diplomat of the American Board of Pathology in anatomic and clinical pathology, and is also board certified in subspecialties of cytopathology and hematopathology. After his practice at the University of Miami and Istanbul Pathology Group in Turkey, he joined the pathology group in St. John Regional Hospital in 2010. He is the division head of cytology and the director of the St. John Regional Hospital Tumor Bank. His special interests include fine needle aspiration cytology, leukemia and lymphoma, flow cytometry, and tissue processing techniques. Today, Dr. Acar will be speaking with us about the general principles of biobanking and his experiences and challenges in establishing and operating the St. John Regional Hospital Tumor Bank. Dr. Acar will be looking at these topics from a pathologist's perspective and examine the advantages of the involvement of the pathology department in biobanking. Thank you for joining us today, Dr. Acar. Please take it away.
Oh, thank you. Yeah, thanks for everybody to joining me. If you realize, I realized today this is the shortest day of the year. So daylight is short. I'm going to keep the presentation, hopefully not short, but on time, probably. I'll finish it up. So I'm a pathologist, actually. I'm not in depth a scientist, I would say, but I do a lot of clinical pathology, hematology, in our department. Our department in St. John Regional is a small pathology department where we still have 12 pathologists, and it's busy with clinical work. So I'll talk about biobanking in general today, and also talk about what we experienced so far in St. John Regional. So I started here in 2010, and the first year when I came, they were talking about the breast tumor bank. So just focused on breast cancer. But these talks and meetings and everything took probably 3 to 4 years before we did really something. There's a lot of challenges. I talk about it too. Just a disclosure, there are no conflicts of interest in this presentation. So I'll talk about the general principle of biobanking today, from biological samples to precision medicine for patients. And I'll also talk about our tumor bank. We call it Tumor Bank in St. John because it's a cancer-based biobank. Initially, that was called Tumor Bank, and we kept the terminology as Tumor Bank from the beginning. And then I'll also talk about the Marathon of Hope Cancer Centers Network and Atlantic Cancer Consortium and the Biobank Consortium associated with the Atlantic Cancer Consortium. So we'll put all things together and go from there. So this is from 2009 on Time magazine. They listed the biobanking with other 10 ideas which are changing the world in 2009, and they listed biobanks. So those are the times, actually, late 90s, the biobanking became kind of a discussion in the scientific meetings, and the standardization and all the legal aspects and everything. So in that time, the Time magazine brought this up, and there are probably more interest after this issue of the Time magazine. So just start with the definitions. So there are multiple definitions, and there's still no agreement on the precise definition of a biobank, actually. So when we started in a simple mind, like, you think you're gonna just get all this tissues, freeze them, and get them from the pathology archives and store them, but it's much more than that. And it's been gradually adopted to describe any collections of biospecimens or human genetic data suitable for research purposes. So The main thing here, I want to make this, emphasize the coexistence of biological samples and associated data. Without data, these tissues are tissues, so you can look at them, do studies, but with the data you store, with the specimens, data you collect, you conclude much more than just what you get from the tissue histomorphology and also next gene sequencing. So typically we collect, store biological materials. They are annotated, not only with medical, but also often with epidemiological data. So they are not static projects. The biobanks are ongoing projects. So we continuously receive specimens and continuously collect data. So they are associated with current and future, not yet specified, maybe research projects at the time of biospecimen collection. We don't know how we're going to use them in the future, or it's currently defined. Let's say we're working on a breast cancer specific topic and we're collecting tissue from breast cancer patients for that purpose only. Actually, the one thing, it's all annotated, and it's very confidential information we collect. But if you find anything relevant to patient clinically during your research projects, so you can always go back to that patient with the relevant information, the patient's, physicians, to provide that information to help patients' treatment. The study is still going on and you find something. So it is not totally anonymized information. They call it pseudo-anonymization. So the classification systems, from simple to more complicated, goes from the first level of classification. We can classify in general like population-based or disease-oriented biobanks, or we can just go further and can classify the biobanks as population study, basic research, translational, clinical trial, pathology archive biobanks, so you can classify them like this, or they actually, you can classify them based on association with the opportunities of biomarker discovery, like biomarkers for individual genetic susceptibility and identity, disease-oriented epidemiology-driven biobanks, so disease-specific biobanks. So another classification can be the type of samples, like we store frozen tissues, formalin fixed, paraffin-embedded blocks, cells, whole blood and derivatives, sometimes urine, buccal cells from the mouth mucosa, bone marrow aspirates, it can include like hair, nails, any feces. It can all be collected and stored. And also, if you have the ability in your biobank, you can extract DNA and RNA. So I'll talk about Canadian Tumor Repository Network. It's called CEDARNet. The CEDARNet actually adopted a classification system, and they classify their actual recommendation for classification in 3 lines. It's the type of donor and participant, the collection method and design, and the second one is features of the biospecimens, like predominant type of biospecimen, preservation, it could be fixed or frozen, and the nature and brand intended users. Nature of the brand and intended users, like a single group, institution, or multiple users on the other end. So this is actually a busy, slide, but I'll just pass this probably quick. So why we collected, there are 5 W's, right? So we just defined the biobanks and why, what, when, and where we collect them and who collects them. Basically, we'll just pass this one. Actually, I'll touch base on this individual in the upcoming slides. Okay, the financial and operational sustainability of the biobanks. So funding is the main thing. Actually, when we started here in 2017, we just kept it very simple, and we said, okay, we are located in the pathology department, and all this cancer tissues, we are responsible for diagnosing and storing them in our department. So why not we start banking them? And but not as simple as this. Of course, I mean, you need ultra low freezers to store frozen material. You need staff. You need a coordinator to coordinate, and so with the simple idea we started, then it became more advanced and complicated with time, and we obtained funding. From the first funding came from the St. John Regional Hospital Foundation, and later on Fairfax Research Institution. So we'll talk about that in the upcoming slides too. So unfortunately, the majority of the biobanks don't have plans for long-term sustainability. So it's probably the same thing for us. We need constant funding to keep this going. And so we are in Horizon Health Network, but we also have collaborations with other institutions. We'll talk about those too. So basically, our biobank, our tumor bank, is cancer-oriented biobank, and we focus on collecting right now colorectal and lung cancers. So it's a continuing process, and the pathology lab plays an important role because we are the ones responsible and to handle the specimens. We have to make sure that they are adequate and fresh when we store them. And we have archives full of tissue, like, with formalin fixed paraffin embedded tissue. So we make sure they are stored well, kept well, so it's an advantage to be as a biobank to be established in the pathology department. So in this slide, actually, the best way to see what we really do is follow the patient. So the patient pathway, as you can see, this lady with a problem, she probably has cancer, detected with imaging studies first. Then in early steps, then she undergoes for a diagnostic procedure. It could be a fine needle aspiration, which these are the fine needles. They aspirate the cells from the tumor, and the cytopathologist looks at the tumor cells and make a diagnosis. And also core needle biopsies. These are actually intact core needle biopsies. They're really small and really challenging to make diagnosis with these. So these samples are usually, they cannot be, stored. They cannot be banked in the bank because they are containing very little tumor or tumor volume, I would say, to be stored. So then after the diagnosis, actually, then the patient comes for surgery usually, right? Or it can be treated before surgery, or it can just go straight to the surgery for cancer, excision. So the surgical tissues, when they come to the pathology lab, of course, we have the patient informed consent. So the OR, OR nurses and surgeons are aware this patient was consented, and from the OR, it comes to our pathology lab, and it is time sensitive, right? The ischemic time for the tissue is very important to preserve the DNA and RNA specifically. So when it comes to the lab, we handle it as soon as possible, and we look at the tissue. If there's enough tumor volume, we get a section, or if the tumor is big, we can get multiple sections to be freezed and stored in the freezers. And you can also, and we also, as a routine practice, we take a section of the tumor and store it with the biobank specimens. So basically, the tissues are handled by pathologists or pathologist assistants in that level. So we have a pathologist assistant and also the lab manager in our lab. They're trained to handle this specimens, and they're also trained to how to, obtain specimens for banking. So then the patient is, when under surgery, then after it could be a chemo or radiation or any therapy after surgery. So we want to collect more specimens. We want to follow this patient, right? So the patient comes for treatment. We can obtain a pre and post-treatment blood samples, right? So what can we do with the blood? We'll talk about it, but there's circulating DNA and RNA in the blood, circulating tumor cells, extra cellular vesicles. These are all kind of techniques that can be acquired through this pre and post-treatment blood samples. And then the patient is treated. I don't know how many sessions the patient can go, like multiple times in chemo, radiation. Then each time, if you can capture you can get the samples, it's better. So we want to follow the patient, and if the patient relapses, the tumor is still there, recurrence or residual tumor left in the patient, and it may get operated again and again. We have the fresh tissue, frozen tissue samples can be stored after treatment. So then, from the beginning, so we aim to collect the pre-treatment samples, post-treatment samples. It can include tissue and blood derivatives. So, and actually there are more like new techniques like primary cell culture or patient-derived organoids, PDOs and PDX can have, we can have those models, like we can have tissue for those studies too. So basically, tissues take sections, and we can do tissue microarrays from the paraffin blocks, DNA, RNA extractions, and proteins. So we can have slice scanning for the tissue sections, and also DNA, RNA, next-gen sequencing, genomic data, proteomics, and it can be all at the end. We're not there yet, but it can be all analyzed by artificial intelligence or other techniques to make sense. So actually, I like this. Explains actually most of the things what we try to do. With our samples, banked samples. So yeah, we talked about this, the vital cells from blood, bone marrow, fetal tissue, umbilical cord, and fertilized eggs or stem cell lines are kind of the new products and procedures. It can be done. we don't have capacity to do this, but I'm just mentioning the technique. So extracellular vesicles, actually, it's one of the studies we are involved with the Atlantic Cancer Consortium in Moncton. They study the extracellular vesicles. So basically, next generation biobanking aims to increase precision in medicine. As we talked about it, monitoring the natural disease history, enriching the clinical data associated with the biological samples, multiple samples from the same patient and tissues collected from patients at different time points, as we just talked about. And the sequential sampling, is important. Then we can see the tumor evolution in the samples we collected from the, pre-treatment, post-treatment, recurrence, or all that. We can compare what happened to the tumor and tumor cells. Okay, so I'm just jumping to our tumor bank. As I said, we named it as tumor bank because we just wanted to deal with cancer. So that's why we named this tumor bank. Biobank is a better terminology name. Anyway, so that was, this is the brochure. I don't know if Vicky is with us, and she worked really hard at the beginning of this. And this was, I think, with her sister. She developed this brochure. So we wanted to just distribute this brochure to all the clinicians and surgeons' offices in St. John Regional Hospital and get them involved. So involvement of the clinicians, physicians, surgeons is very important. So we can't really do anything without a patient-informed consent, and we cannot do this without this surgeons believing in this. So so we just kind of distributed this to surgeons and surgeons' offices. When the patient comes, they kind of can read about it, see it. But honestly, at the beginning, in 2017, we started doing this, and we visited the surgeons in tumor rounds and everything. So we couldn't really we couldn't get them involved enough at the beginning. So basically, then that was kind of dormant, but we couldn't do much with our biobank from 2017 for a couple of years. But we put everything together in terms of standard operating procedures, the governance structure. It's very centered in the pathology lab. Yeah, this is an example of what we simply do with the tumor. You can see this is a kidney tumor, actually. The kidney is cut in half, and there is a large tumor here. Let's say we got this fresh from the OR, just out from the patient. So we expect the surgeons and nurses to record the time the tissue was taken out from the patient. So it is important we time that to the time we get the specimen in the lab and freeze it. So it's called ischemic time, right? So we get at least one section of the tumor. So this tumor is pretty big here, as you can see. So we can get maybe more than one, maybe 5, 10 sections of the tumor. And we also get a sample of the normal kidney here, right adjacent to the tumor. So we'll be able to see the tumor and the adjacent normal tissue. So we freeze some, it's freezing is good. We, it kind of, it's good for the DNA and RNA, especially for RNA. And we store them in freezers, ultra-cold freezers, and molecular studies. It goes for next-gen sequencing or whole genome sequencing. So the timing, the ischemic time is important, and handling of the tissue from the patient to the freezer, and after that, processing has to be really due to according to the SOPs we have. So the other thing is that these are routine paraffin tissue blocks we have in pathology department. That's the tissues are embedded in paraffin and cut in 4 to 5 micron thick sections, and then from these blocks we can create tissue microarrays. So you can put, as you can see, up to 40, 50 patients on one slide. And if you want to study, like, multiple patients at once, and you can do immunohistochemistry or other studies on one slide, and you cover 40, 50 patients on one set of immunohistochemical stains. It's really cost effective. Okay, so St. John Regional Hospital, as I said, it's established in 2017 late, and we use the guidelines for set out by CEDARNet, Canadian Tissue Repository Network, and our biobank is certified, registered and certified by CEDARNet. And we adapted the SOPs from the CEDARNet established protocols. And we always thought about, from the beginning, expanding this to the additional sites in Horizon Health Network after we established our tumor bank. So CEDARNet, we just have to talk about this because it is it's a nonprofit association, and it wants to establish, promote, and disseminate standards for biobanking. So that's what their goal is. Established in 2004. So they created actually SOPs that we adopted, and also there's a platform, Atom. It's a software for data banking. So Atom is the biobanking software, and it is designed and developed by CEDARNet. And I got this from their website, the latest information. I think has been deployed in 38 biobanks, they say, and manages the data of more than 45,000 recruited participants and nearly 1.2 million aliquots. So this is an open source software. We started with Atom, but recently we are participating with the other biobanks consortium. So we decided, actually, that was not easy to use for us, so we decided to switch to RedCap. And there was a long, I don't know if Stephanie Krepler, when she was in Vitality, and, getting the CEDARNet, privacy assessment and all that, it took a long time. But at the end, that was not much friendly for us to use. So the decision was made to switch to RedCap. So these are the types of samples we collect and clinical data. So we collect tumor tissue, normal adjacent tissue, peripheral blood. We haven't started yet, but we have a new research technician started, and we are planning to start getting peripheral blood before surgery, and after surgery, pre and post treatment blood. Just follow the patient and do plasma and Buffy-coat. Also, we have fresh frozen tissue, slides, paraffin embedded tissue, cryopreserved plasma and buffy coat. We are planning to collect, the clinical data has to be, the RedCap is going to be the platform we're going to put the data in. It's already, some data is already collected, but we need more work on this to collect more data from this patient and enter the, RedCap software. And RNA, DNA extraction, and tissue microarrays also in our capability. But with the project we are in right now, we are actually shipping them to Acar, and they are getting the whole genome project. So I'll talk about that again. Like I have to just talk about from in our perspective in St. John Regional Hospital. Then I'll talk about the provincial and national efforts. So again, we're a pathology-centered biobank, and we talked about the ischemic time. It's very important from the tissues coming to the lab as soon as possible, and we process this as quick as possible to protect the DNA and RNA in the tissue. So we receive it. Accessioning is another step. So we look at the tissue, or pathology assistant evaluates the tissue, obtain the tissue for the bank. So it is really important. The one challenge was the speaking with clinicians and surgeons to get them kind of involved. The second, maybe more importantly, I have to convince my colleagues here in this pathology department, because when it comes to the diagnosis of cancer and kind of doing the all staging, pathologic staging, we need enough tumor, good amount of tumor to work on. So we cannot really compromise the diagnostic material. So in this slide, I'm showing you a lung section. This is the probably the right lung. It has two lobes, upper and lower lobe. Here in the lower lobe, there is a tumor. So it is a good sized tumor. So our set is like, if the tumor is less than 2 centimeters, discuss it with the pathologist. If the pathologist assistant is handling the tissue, to make sure that we have enough for diagnosis and also for staging. So this is the current classification of lung adenocarcinoma. So there are like multiple types of lung cancers. The adenocarcinoma is categorized in the non-small cell carcinoma category. It's one of the most common ones. So the pathologists actually are nervous when we get this specimen, because we don't want to compromise the tissue, right? Take it for banking, and you don't have tissue, because when you get a tissue for freezing, you freeze the tissue, you cannot go back to look at the morphology anymore. So we make sure we get a sample from the center of the tumor. Don't mess with the pleural surface. If it is involved, it's change the staging. So here you can have an in situ carcinoma. It's totally depend on the size of the in situ extension of the tumor. Right in the middle, it's minimally invasive carcinoma. Basically, it is really like you have to measure if you have in situ carcinoma and you have 5 millimeter invasive cancer only, up to 5 millimeter, it's called minimally invasive adenocarcinoma. And the invasive carcinoma is more than 5 millimeter invasive carcinoma. So it's really like really detailed, information. We need to look at the tissue and get all this information. And if the tumor is small, we don't take a chance and don't really get a section for banking. So I just have to mention this because I talk to our pathologists daily and make sure that we are not really compromising data for diagnosis. Okay, now we're going to talk about the Fairfax Research Institute Marathon of Hope pilot project. We started this, it's been 4 years probably. So we joined the Atlantic Cancer Consortium. So basically, this has developed an integrated foundation of precision medicine for the Atlantic region. And this pilot project was focused on colorectal and lung cancer. Basically, this is kind of explains it. There are 5 cores of the consortium. The first is the Atlantic Canada Biobank Consortium, and it includes 4 institutions actually, and St. John's Newfoundland Memorial, St. John Regional Hospital, Horizon Health from St. John, in Moncton, Vitalité, the George Mon, and Halifax NSH in Nova Scotia, all participants of the Biobank Consortium. So actually Cancer Consortium in general, but we all also have biobanks now. In Halifax, they had it for a while. We started in ours, and we started in 2017, but we are functional in the last 4 or 5 years. So basically, this was the goal of Fairfax Research Institute, Marathon of Hope, is to create a network of regional cancer centers across Canada. So each center will include a biobank that contains both patient biological material and patient data, including history, diagnosis, treatment, and outcome. So the Biobank Consortium, we participated as our tumor bank. So the overreaching objective was to create a unified biobank network that shares the best practices and operational efficiency across Nova Scotia, New Brunswick, and Newfoundland. So, and we already developed this actually, harmonized practices and in 3 provinces, and provide opportunities for cancer patients to participate in clinical trials and share patient material and clinical data in support of cancer research. So Atlantic Biobank Consortium and the goals we had and all achieved now, we had short-term 2-year goals. We initiate the Atlantic Canada Biobank Consortium, harmonize governance structures, patient consent forms, and standard operating procedures among the biobanks. And the website was launched for the consortium. The server is in Dalhousie. And we obtained the CEDARNet certification for the individual banks and also for all participating biobanks. So harmonized database with Atom software, that was the initial effort, but lately in 2023, decision made to use RedCap instead of Atom as the database software. So the data is not really uploaded. We still don't have RedCap. I think Stephanie Cropley and other coordinators that I know in Horizon are working to get the RedCap approved and put in use. I don't know what's the stage of that right now. Maybe Stephanie can tell us about that.
Yes, Cenk, it's in the work.
On the work. Okay, as usual.
Yes, but it's moving forward, which is a great news at least.
Okay, great. So the long-term 5-year goals were to leverage the consortium website, facilitate research collaborations and clinical trials through this 2 colorectal and lung cancer collections. And also we want to expand it to the other tissue types and biological materials. Multiple myeloma, I have to mention that actually Dr. Tony Ryman's lab also has their own biobank, and it's been a while. They were collecting multiple myeloma specimens, and they are involved in studies that I will mention a little bit later. So, okay. So basically, these are the brochures for our tumor bank, and this is the main page of the Atlantic Canada Biobank website. And now I'm just going to jump and talk about Marathon of Hope Cancer Centers Network. So basically, we all know Terry Fox. This is inspired by Terry Fox, and the goal is uniting Canadian researchers to improve cancer care through precision medicine. So basically, the goal is just to collaborate, build platforms and collaborate between the cancer centers established in Canada, and then they basically, close the gap between research in the lab and the patient care in the clinic. So it's just aim is to unite cancer researchers and pursue that same goal with precision medicine. So the goal is creating the Team Canada of cancer research to improve outcomes for cancer patients through precision medicine. So there are some quick facts named in honor of Terry Fox's journey to raise funds for cancer research. Then unites the scientists and clinicians from cancer research institutes and hospitals across Canada to share data, harness new technologies, and create unprecedented collaborations. And it is funded by the government of Canada with $150 million over 5 years, but it's to be matched by the network partners. So the aim is to create Canada's largest cancer case database. This is the gold cohort of MOHCCN. And the goal is just containing 15,000 cancer genomes and with related clinical data within 5 years. Okay. So the key achievement so far with the network is 24 member institutions they have from all 10 Canadian provinces. Establish a network governance structure with all regions represented. Formed 11 working groups, from the leaders through the country, working together, and provided 3,000 cases representing 22 cancer types for the gold cohort by 60 cohorts from 5 regional consortia. Completed a pan-Canadian request for application that has helped identify 21 new cohorts that will bring over 6,000 new cases for the network. There's also training and support training and next generation of experts in precision medicine programs for training. And this is, I kind of extracted this from the website, their website, and you can see the consortium, 6 consortia and current members. As you can see, the Atlantic Cancer Consortium here, University of New Brunswick, Memorial University of Newfoundland, Eastern Regional Health, Atlantic Cancer Research Institute, Acar in Moncton, Vitalite, Horizon Network, Dalhousie, PEI, University of PEI, and Nova Scotia Health Authority. So basically, these are the numbers. BC is far away, far ahead. They started earlier with this project, and they have the 1,180 full genomes profiled so far. So if you look at the other consortium, they are far ahead. So in Atlantic Cancer Consortium, we have only 5% for now, but we are relatively very new compared to the other sites. So this is the data. It was from April 2023. And it shows that 3,146 full genomes profile and 705 cases completed with clinical data. So it's an ongoing, process. We are still working, collecting our specimens and collecting data to complete, work with the consortium and get to the point that we can, do all potential cases from our sites. So these are actually the ongoing projects under the Atlantic Cancer Consortium. This is Dr. Ryman's, the first one, the Canada Myeloma Cohort Project, and all others. So these are all ongoing projects, and we are participating as St. John Regional Hospital. Anyway, we can help the researchers to provide high quality samples for their research. So in summary, we talked about the St. John Regional Hospital Tumor Bank. It's launched in late 2017. It's a pathology-based biobank focused on cancer research. And we use the CEDARNet guidelines. We are registered and certified by CEDARNet. We are a member of the Atlantic Canada Biobank Consortium and part of the Marathon of Hope Cancer Network. And currently, we are only banking colorectal and lung cancer samples, but we'll expand it to the breast shortly, real soon. And we're going to start collecting breast. And being in St. John Regional Hospital, we are kind of restricted. We wanted to collect gynecological cancer, like ovarian cancer, but those patients goes to Moncton and for surgery, and we don't have access to those now. We are planning to probably in the future collecting prostate cancer. And actually, our goal from the beginning to expand this to the additional sites in Horizon Health Network. It is possible, but it's a lot of work, and and the best way to, if we go from the other Horizon Health Network sites like Fredericton, Moncton Hospital, and other sites. So it's best way to start with the pathology departments and pathologists, in my opinion, to be more successful. And yeah, this is the end of my talk. Thank you for your attention, and I like to thank Dr. Tony Ryman. He's a medical oncologist, as we all know, and he is the consortium leader for Marathon of Hope CCN. And I'd like to thank Vicky. Vicky was here with us. She had a lot of effort starting our biobank and preparing all this RAB applications, RAB approvals, even the brochure that I showed you, she developed that and designed it. And Nick was with us last week. He left us and he started a new job, and but he put a lot in the last 2.5 years. I think he was with us as a coordinator. And Heather Richard is the lab manager, and she oversees the operations in our lab, and she is great, and she helps us with everything we need. And Misty is our pathology assistant, and she handles most of the tissues coming from the OR. And she consults the pathologist if it's necessary. Otherwise, she goes ahead and takes her samples, and she's very efficient with that. And Holly Sanders, she just joined us, very new, and she'll be taking some of the responsibilities that Nick had. And we also have some coordinators from Dr. Ryman's team to make sure that we are getting patients involved and getting the informed consent through the coordinators, and they're going to help us to obtain data and enter data to the software when we have the REF cap.